of my talk is the role of vitamin D in reproductive and health of men and women. In the last decades, there is increased scientific interest in vitamin D effects on the other parts of the body besides bones, including its effects on immunity, endocrine, cardiovascular, and reproductive function. In parallel, there is increased awareness about a global pandemic of vitamin D deficiency, particularly in women with pregnancy. There is high prevalence through all the world. Interestingly, the highest prevalence is in the center part of the globe, where is the highest insolation. So the causes of vitamin D deficiencies are many, including inadequate intake through food or supplements, not having enough sunshine because of modern lifestyle, because of cultural and religious reasons, and some personal factors can also interfere, including genetics, age, ethnicity, and obesity. The link between obesity and vitamin D deficiency is bidirectional. Obesity can worsen vitamin D deficiency by sequestration of vitamin D into adipose tissue, by volumetric dilution, and by impaired vitamin D metabolism in the adipose tissue and the liver, for example, in decreased activation and increased inactivation, but also because of the obese person lifestyle, lack of outdoor activity, and limited sun exposure due to increased clothing. As we said, the association is in both ways. Obesity can worsen vitamin D deficiency, but vitamin D deficiency can influence obesity. It can influence adipose tissue differentiation and growth through regulation of the genes in the adipose tissue, through modulation of parathyroid hormone secretion, calcium metabolism, secretion of adipokines, through its effects of metabolism, insulin resistance, insulin secretion, oxidative stress, inflammation, and gut microbiota. There is enough evidence that polymorphisms of vitamin D receptors are associated with obesity. However, vitamin D supplementation is not associated with the weight loss, while weight loss has little effect on improving vitamin D status. In contrast, the association between insulin resistance, metabolic syndrome, and vitamin D deficiency is much more established. Through different effects of vitamin D in different parts of the body, including adipose tissue, muscle, liver, guts, pancreas, vitamin D can influence insulin sensitivity and beta cell function, and therefore can improve both of them. Vitamin D is also involved in inflammation. It can decrease production and action of pro-inflammatory cytokines and increase the production and action of anti-inflammatory cytokines. Just a short reminder of the metabolism of vitamin D in the body. After its resorption from guts or synthesis in the skin, vitamin D comes to the liver, where it passes through 55 hydroxylation, first step in its activation, and in this form is the most abundant in the body, can be stored in the adipose tissue or released into circulation, bound to vitamin D binding protein, albumin, or in the free form. It comes then to kidneys, where it comes to the last step of activation, 1-alpha hydroxylation, to form active form of vitamin D, which can then exert its genomic, non-genomic, and epigenetic effects. Genomic effects of vitamin D are very well known. By binding to its vitamin D receptor, complex comes to nucleus, where it binds to vitamin D responsive elements in DNA and regulates gene transcription by increasing or decreasing gene transcription. But besides that, it also has its non-genomic rapid effects, which are related to binding of vitamin D to its membrane receptor, which then activates the full cascade of second messengers, which can then activate certain kinases, phospholipases, will then activate some enzymes or inactivate enzymes, or are going to be involved in gene transcription control. Vitamin D receptors and enzymes involved in metabolism of vitamin D are distributed through all the parts of endocrine system involved in reproduction, including hypothalamus, pituitary gland, testes and ovaries, adrenals, fat tissue, liver, bones, prostate, seminal vesicles and epididymis, breast, fallopian tubes, uterus, endometrium, myometrium, trophoblast, and placenta. All of these organs are included in sex hormone metabolism, production of sex hormones, production of gametes, and conception and pregnancy. The effect of vitamin D in those tissues include its direct both genomic and non-genomic actions. In addition, by influencing insulin resistance, inflammation, and oxidative stress, vitamin D can improve reproductive function because insulin resistance, inflammation, oxidative stress negatively influence reproduction function both in men and women. Finally, through its influence of calcium metabolism and availability of calcium, it can improve reproductive function because calcium promotes steroidogenesis and development and function of gametes. In ovaries and testes, vitamin D can influence steroidogenesis and gametogenesis via its direct genomic and non-genomic actions. For example, acting directly on enzymes involved in steroidogenesis, but also indirectly by its interaction with calcium homeostasis, steroid receptors, androgen, estrogen, progesterone, and glucocorticosteroid receptors, gonadotropin receptors, and anti-Müllerian hormone receptors, various nuclear factors, growth factors, cytokines, reactive oxidative species, advanced glycation end products, and their soluble receptors, which are all involved in steroidogenesis and gametogenesis. The same direct and indirect actions are noted in all other organs, tissues involved in production and metabolism of sex hormones, conception, and pregnancy, which I already mentioned. Additionally, as I said, vitamin D influences insulin resistance, inflammation, and oxidative stress, which represents an indirect influence on reproduction. In testes, epididymis, seminal vesicles, and prostate, vitamin D increases testosterone and estradiol production and supports spermatogenesis and sperm development in action, motility, capacitation, and acrosome reaction. In ovaries, endometrium, myometrium, and placenta, vitamin D increases production of estradiol, progesterone, anti-Müllerian hormone, and improves ovarian follicle survival and development, oocyte maturation, luteinization, and function of corpus luteum, endometrial development, implantation, placental development and function, and protects from early pregnancy losses, preeclampsia, fetal growth retardation, fetal death, and premature delivery. The mechanisms include its direct influence on enzymes involved in steroidogenesis and its influence on gonadotropin, anti-Mullerian hormone, steroid receptors, as well as I said, oxidative stress, inflammation, and advanced glycation. Just to remind you of the process of steroidogenesis from cholesterol, there are plenty of enzymes involved in the production of steroid hormones, including sex hormones. In pituitary gland, it decreases LH secretion. In adrenals, it decreases cortisol, aldosterone, and adrenal androgens, DHAS, and androstenedione production by influencing steroidogenesis. In adipose tissue, prostate, breast, placenta, and skin, it affects steroid intercompression by influencing enzymes involved in it. In the liver, it influences production of sex hormone binding globulin, which binds sex hormones and lowers their bioavailability for target tissues, and influences also metabolism of steroids. In bones, it stimulates production of osteocalcin, which increases testosterone production in testes and decreases aromatization of testosterone to estradiol in adipose tissue. The link between reproduction and vitamin D was first noted in animals. In many animals, there is seasonal breeding, which with decreased breeding during summer. In rodents, the experimental vitamin D deficiency resulted in lower mating rates, fertility rates, birth rates, in males lower testosterone levels, testicular degeneration, worse sperm parameters, including lower sperm number, viability, DNA integrity, motility, capacitation, acrosome reaction, and fertilizing ability, and in females, impaired oocyte maturation and ovulation, decreased implantation and deserialization, lower litter size, and neonatal growth retardation. However, supplementation of these animals with vitamin D normalizes their fertility. On the other side, also very high doses of vitamin D could impair infertility. In female rates, supplementation with very high toxic hypercalcemic doses of vitamin D led to alteration in estrous cycles, hypofunction, atrophic changes, together with reduced hormonal production, with decreased pregnancy rates, and impaired deserialization. Again, these effects were reversible. In knockout animals, female alpha hydroxylase knockout and vitamin D receptor knockout mouse had infertility, uterine hypoplasia, impaired folligenesis, decreased aromatase activity, decreased estradiol levels, and increased LH and FSH, which indicates hypogonadotropic hypogonadism. However, some of those vitamin D knockout animals had normal fertility, particularly if they were normocalcemic. Regarding the males, vitamin D receptor knocked out males had decreased sperm count and motility, but their reproductive phenotype varied from complete infertility with normal testis morphology, with abnormal testis morphology and hypogonadotropic hypogonadism, to near normal fertility with normal testis morphology, normal hormonal levels, and but still increased LH to testosterone ratio and Leydig cell hyperplasia, indicating lower testicular responsiveness to LH stimulation. In difference to female mice, one alpha hydroxylase deficient male mice had normal reproductive organs. Defects in levels in metabolism of vitamin D can adversely affect reproductive function also in humans. Vitamin D insufficiency or deficiency were associated with reduced fertility both in men and women, with high rates of reproductive abnormalities, including hypogonadism in men, syndrome of polycystic ovaries in women, endometriosis, leiomyomatosis, and premature ovarian failure, lower pregnancy rates, higher pregnancy complication rates, preeclampsia, gestational diabetes mellitus, spontaneous pregnancy losses, preterm birth, fetal growth retardation, increased postpartum and postnatal morbidity and worse neonatal development, and increased risk for reproductive tract carcinoma, including ovarian, endometrial, breast, and prostate carcinoma. Similar as in animals, in humans, in northern countries, the highest successful conception pregnancy rates are reported during summer or autumn, where the levels of vitamin D in the blood are the highest. Regarding men, some studies showed that vitamin D receptor polymorphism was related to the increased risk for infertility in men, and that infertile and hypogonadal men have lower serum vitamin D levels and higher prevalence of vitamin D deficiency and insufficiency, together with decreased testosterone, LH, FSH, and increased estradiol and cortisol levels. However, not all studies confirm this relationship. Vice versa, observational studies also show that men with vitamin D insufficiency or deficiency have often lower sperm motility, concentration, and viability, lower testosterone, free testosterone, and SABH levels, higher estradiol levels, lower testosterone to estradiol ratio, and higher or lower LH levels. However, these findings were not confirmed by all studies, and there was a significant compounding influence of degree of obesity and age. Similarly, some studies showed a positive correlation of vitamin D concentrations with serum testosterone, free testosterone, SABH levels, and testosterone to estradiol and cortisol ratio, and negative correlations with serum estradiol, cortisol, and LH levels. Again, these studies findings were not confirmed by all studies. Some findings were even opposite, and there was a significant compound influence of degree, obesity, and age. Seasonal variations for serum testosterone levels, the peak of testosterone in the summer period, were also shown by some studies, but not by all. Similarly, testosterone to cortisol ratio was the highest in the summer. There were also positive correlations of serum and seminal fluid vitamin D concentrations with semen volume and sperm quality parameters, sperm motility, count, morphology, and fertilizing ability, capacitation, and acrosome reaction. Interestingly, also high levels of vitamin D were related to decreased testosterone levels in men, and seems that there is a U-shaped curve in the association of vitamin D with testosterone and sperm quality. Surprisingly, most interventional studies with vitamin D supplementation in men didn't confirm a significant effect on testosterone levels, fertility or pregnancy rates, or sperm quality. The most confirming data were related to the increased sperm motility and less to the increased sperm count. Regarding women, also in women with infertility and a high prevalence of vitamin D deficiency was often noted, particularly in the obese ones, and the results of in vitro fertilization and other assisted reproductive treatments have been worse in vitamin D deficient women. Conversely, in vitamin D deficient infertile women, vitamin D supplementation increased the success of in vitro fertilization and other reproductive treatments. Vitamin D polymorphism, vitamin D receptor polymorphism was associated with female idiopathic infertility, polycystic ovary syndrome, PCOS, endometriosis, preeclampsia, and in vitro fertilization success in some studies, but not in all. The data on the effect on vitamin D on ovary function are still limited, often contradictory, and much more studies are needed. The studies on the follicular fluid concentration of vitamin D revealed positive, negative, or no correlation with pregnancy rates during in vitro fertilization, positive, negative, or no correlation with estradiol and progesterone levels, positive correlation with SABG, negative or no correlation with total testosterone, free testosterone, and DHA levels, and free androgen index. However, data were often conflicting and confounded by age, BMI, and other factors. Regarding women with PCOS, serum and follicular fluid vitamin D levels are generally lower in women with PCOS, independently of body mass index, and correlate with the level of hyperandrogenism, positive correlation with sex hormone binding globulin, and negative with free androgen index, total testosterone, androstenedione, DHS, and level of hirsutism, with infertility and pregnancy rates during assisted reproductive treatments. Among patients with PCOS, the lowest level of vitamin D had insulin resistance and obese infertile PCOS patients. However, also lean PCOS patients had lower vitamin D levels compared with BMI matched controls, in parallel with increased insulin resistance and leptin. Seems that insulin resistance, obesity, worse the effect of vitamin D on reproduction. Vitamin D receptor binding protein and 25 hydroxylase polymorphisms have been found to be connected with PCOS. Follicular expression of vitamin D receptor was found to be decreased in PCOS, while vitamin D binding protein expression was found to be increased. However, again, the clinical data on the effect of vitamin D supplementation in PCOS revealed inconclusive results. Some of them, but not all, showed improvement in the hormonal, clinical, reproductive, or metabolic parameters, and found positive effects on improved fertility in PCOS, particularly women with low vitamin D levels. Suggests regular screening for vitamin D levels and adjuvant vitamin D therapy in infertility treatment for women with PCOS. The mechanisms by which vitamin D influences the improvement in hormonal, reproductive, and metabolic parameters in PCOS include both effects on vitamin D on insulin sensitivity, glucotoxicity, lipolysis, and lipotoxicity, and its inflammatory and antioxidative actions, as well as specific and direct effects of vitamin D on steroidogenesis, follicular genesis in ovaries and adrenals, leading to decreased testosterone, DHSS, androstenedione, cortisol, and anti-Müllerian hormone production. Also, vitamin D increased production of sex hormone binding globulin in the liver. However, there are not many studies in vitro on the effect of vitamin D in polycystic ovaries. Even there are some studies in animals, but not in the humans. Additionally, low vitamin D is related to endometriosis and rheumatosis by its effect on immunomodulation, anti-inflammation, pro-apoptotic and anti-proliferative activity, as well as stimulation of degradation of extracellular matrix components. Vitamin D is additionally related to premature ovarian failure, probably due to increased follicular atresia. There is positive correlation between vitamin D and anti-Mullerian hormone as a marker of ovarian reserve in the women without PCOS, but with the women with PCOS, there is a negative correlation between two of them. And supplementation with vitamin D increased anti-Mullerian hormone in women without PCO, but with women with PCO had opposite effect. Finally, low vitamin D is connected with certain cancer forms. Vitamin D levels and vitamin D receptor polymorphisms were linked to ovarian, endometrial, breast, and prostate carcinoma risk, progression, and prognosis. In conclusion, there is enough evidence that vitamin D is involved in reproductive system, both in men and women. Circulating vitamin D levels, its bioavailability, and polymorphism of vitamin D related genes can influence reproductive health of multiple levels, from infertility, pregnancy outcomes to cancer development. Therefore, regular screening for vitamin D levels in departments which deal with reproductive health is advised, along with measures of vitamin D for vitamin D deficiency and insufficiency corrections. However, more research is needed in that field. Thank you for your attention.